These slides are the ones that CHOP gives you, because everything has to be coded exactly as CHOP wants it to. But I actually love this picture, and believe it or not, this is what our hospital looks like at night. It's not manufactured. I, unfortunately, about a year in it being at CHOP, had to take one of my coworkers to the emergency room next door. And for those of you that work in a hospital that has a NICU, but it's in an adult hospital, you get really used to, if you need something, you just go to the emergency room and they give you what you need. When you work in a standalone children's hospital, you don't have that option. They make you go next door to the adult hospital and actually sign in and have to go through triage and go through the process. So it was late at night when I walked past the hospital to get to my car again, and it actually does really look like that, which is interesting. So a couple conflict of interests that I need to disclose. I have a research relationship with Neonatal, which is a Japanese company that does a lot of monitoring. Don't have a huge presence yet in the United States, and Draeger as well. We're going to do a little bit of an overview here. What the literature tells us about ventilation in our neonatal population, as well as some of the challenges in implementing these various recommendations that they give us, because as we know, everything works well when it's a nice controlled setting in research or in a bench lab, but it's not always practical for us to implement at the bedside. Some of these recommendations are a little soft because they're not easily implementable, or there really isn't a whole lot of evidence to support what we say we need to do. So when we talk about expert opinion, it's because they're the experts. They do a lot. An expert is the people chose you, you, and you, and now you're our experts, and tell us what you think we should do. But there isn't a whole lot of evidence, research evidence, to support what they're saying. Large airway leaks, which we have in our population with the uncuffed endotracheal tubes. And in looking at the differences in tidal volume accuracy, the use of the flow sensors, and actually all the different ventilator settings that are kind of a bit of a challenge that we don't think a lot about that can make a big difference in ventilation in the NICU. So looking at some of the evidence, I'm going to piggyback a lot on what our first speaker talked to us about today, and we really need to look at neurodevelopmental outcomes as well when we're talking about ventilation. It's not something that's often coupled together. It's something that we need to start, in my opinion, coupling together a lot more, and that we're going to see a lot, because everything that we do makes a difference on these developing brains, and we have to really think about that as we're going through with the care. So hyperventilation with hypocapnia causes cystic brain lesions and periventricular leukomalacia. We know this happens. These are studies that have proven this for years. We don't always necessarily pay attention to it. So breathing too fast, making our CO2s go really low is really bad for the brain. So when we're in that stress situation in the delivery room, or when there's a code in the NICU and we're bagging, it causes a problem that we don't necessarily think about. We're only thinking about getting immediate gratification from that instance, which is start breathing again and get your sats up. We don't think about the long-term damage of overventilating during that time frame, and we really need to. Hypercapnia increases the risk of intraventricular hemorrhage as well. So on the flip side, we can't let our CO2s go too high either. So you need to be able to find that sweet spot. We need to be Goldilocks here. So where does the best CO2 ranges that we really need to be at for our babies? In our pediatric and adult population, when we have patients with really sick lungs, we don't worry about their CO2 so high. Sometimes we'll see them in the hundreds as long as their pH is intact. We can't really do that in the NICU. We really have to watch those high CO2 levels because they, again, can cause some bleeds. And we really want to make sure that we're not the ones causing the problems. Ventilating with low peak inspiratory pressure and low peak pressures can lead to atelectatic trauma and ventilator-induced lung injury. There's several different levels of ventilator-induced lung injury that we talk about. Atelectatic trauma is one of the ones that we don't concentrate on as much, and that's predominantly when your alveoli close, they kind of suck together, and then they have to pop back open. Every closing and popping back open causes trauma. So we need to try to stop that popping back open from happening, and the only way to do that is to stop them from collapsing completely. So we need to use a high enough PEEP level. And bronchopulmonary dysplasia, which is the one that we all are very focused on, death or bronchopulmonary dysplasia, because it's one of the long-term outcomes that, or shorter term, I guess we could even call it, outcomes that we see before they actually leave the NICU. A lot of the neurodevelopmental ones you don't see until they're not crawling when they should, or they're not being able to sit up. So we don't really see those effects unless your NICU has a reunion and you see your kids come back all the time. So it's something that we tend to not focus on as much as we probably should. So looking at some of our current evidence, I'm going to go through some of the studies, what they really tell us. Some of these are old, but it doesn't really matter because they kind of prove their point. We don't really need to look at it anymore. Mechanical ventilation increases both cerebral pressures and fluctuations in the cerebral and venous flow velocity. So we know that this happens. We know that with high-frequency ventilation versus conventional ventilation that we really see these things occur. And some of these I've put some of the significant references down. Elevated levels of inflammatory cytokines, which are found in the lungs, which tell us we know there's going to be some sort of lung injury occurring when we can pick out these inflammatory cytokines. We now believe that they also can cause white matter damage in the brain. So it's not just affecting the lungs when we see those. It could be affecting other organs that we're not sure about as well. And this was in 2008. This wasn't this year. So this is something that we've known. It's a very well done study. However, it's not something that is talked about widely either. Routine suctioning and repositioning of the endotracheal tube causes changes in cerebral hemodynamics and oxygenation. We do this all the time. Can you imagine every single time we disconnect them from the ventilator to flip them over because it's easier and you don't have to have another person there with you at the bedside, and we just connect them back up and it's not that big of a deal? It could potentially be causing brain damage as well as adolescent trauma. So really some of the little things that we do for the care of them, and because they're really small, we should be able to do it by ourselves. We ignore all of the, well, we really should have a second person anytime we're doing this, have a second person there anytime we're doing that. It's not really just about the endotracheal tube coming out. It's about all of the damage to the lungs and the brain that can occur during that time. Also, looking at our long-term neurodevelopmental disorders and the risks that mechanical ventilation causes. There was a really good study that just came out actually this year in Research and Developmental Disabilities Journal. And they looked at a 10-year retrospective review on a follow-up info for their extremely low birth weight infants that were born between 1998 and 2001. And we all know that the practice of how we cared for our babies between that time frame did vary quite a bit, so we have to take some of this with a grain of salt, since it is a retrospective analysis, but important nonetheless. Their outcome stated that being on mechanical ventilation for greater than or equal to 15 days increased the risk of cerebral palsy and ADHD, even without having any sort of significant neonatal brain damage. Just being on a ventilator. It's significant. They didn't distinguish here whether it was for a respiratory disorder, for something surgical, for something cardiac. They looked at all of them. So there wasn't one that even came out higher than the others. They saw no correlation between the autism spectrum disorders and any sort of intellectual disability. So that was one of the things that kind of came out but went away is, being premature make you more susceptible to getting autism? Does it have to do with the development? And according to this review, there wasn't any sort of a correlation there. So at the end of this, they recommended developing brain protective respiratory strategies in response to real-time hemodynamic and oxygenation changes. What the heck is a brain protective respiratory support strategy? It's the first time I heard it. It makes sense, though, considering all of the past evidence, and that was just a little handful of it that I put out there for you, of what being on a mechanical ventilator causes to our brains. So we'll come back to that. So looking at all of that, overwhelmingly, which is what the current evidence tells us, is don't intubate. Don't go on a mechanical ventilator. Use non-invasive support as much as you possibly can. And there are a lot of centers that do that at delivery, and I'm sure many in here will go on CPAP, will go on mask or prongs. With the NeoPuff, we'll even do non-invasive ventilation, and we tried our hardest not to intubate. A lot of centers, Columbia, as coined as everybody knows, is the best center for your lung outcomes. They have very strict guidelines as to when you fail and need to be intubated, which is generally when you get surfactant. And those who don't, as long as you don't need the surfactant, you don't get the surfactant. They don't do it automatically, as some other centers will do intubate, surf, and then extubate right away so that you're not on a ventilator a lot. But we're not here to talk about non-invasive ventilation. We're only going to talk about invasive ventilation. So we know that there is definitely something out there that tells us we still have to worry about invasive ventilation. We cannot keep everybody off of it, even though that's what all that evidence is telling us. So I'm sure most people in the room are familiar with the support trial. This was the study to understand the prognosis and preferences for outcomes and risks of treatment. And as you know, any neonatal study you do has to have some nice little phrase or acronym or something, and I have to write them down. I can't remember what all of them mean all the time. But a lot of things came out of the support study and this trial, and a couple of the things to point out that they found. 35% of their 24 to 28 weekers that were randomized to the CPAP-only arm at birth ended up getting intubated in a delivery room. 35%. And of those that didn't get intubated in a delivery room and made it downstairs on their CPAP, 83% of them required intubation at some point during that trial. So just saying don't intubate doesn't really happen. And the support trial was heavy on really we should be able to just use CPAP. But these are some of the outcomes from that study that aren't widely shared about because that's not what's in vogue right now. It's not sexy to intubate somebody. It is to keep them off. So that's what's out there. But there definitely is still a need to keep people intubated. The major causes of to why they needed intubation was poor gas exchange, increased work of breathing, apnea, prematurity, and the need for surfactant. And of course, we need to avoid hypo or hypercapnia. So we have to keep those CO2s in that sweet spot to make sure that we're not causing too much brain damage. So you really don't want to have your CO2s below 30 at all. Sometimes we'll get blood gases back and we see a CO2 of 20 and they're like, oh, well, let's just not change. Let's get another blood gas in 5 or 10 minutes. We really should be making a change then because any time below 20 or really below 30, you're causing some damage. So we really need to try to keep those CO2s, making smaller changes more often to try to keep us in that sweet spot. So how we ventilate in each one of our settings really makes a difference. So we need to think about each one of these different settings that we don't always think about that can really help. Our mode, which is a big one. There's a lot of debate about modes. But our PEEP and eye time. Eye time is not one of the ones that people talk about a lot. And sometimes even PEEP, they're kind of set it and forget it settings, or if they're a preemie, or if they're close to term, or if they're term, they get the same eye time or they get the same PEEP level. And we really shouldn't. And when we're talking about individualized medicine for everything, that includes our ventilation strategies. We really should be giving people what they need at the time they need it, taking a look at what we really need and not doing the set it and forget it. I know in the last NICU that I was in, which was a preemie NICU before I went to CHOP a couple years ago, we didn't change our eye times. And I had so many arguments at the bedside with my neonatologist to say, listen, I'm 4 months old now. He's 4 months old. Why do I still have a 0.30 eye time? It just doesn't make sense. And it was very, like, I tweak it up because it was one of those settings that wasn't in order for us at that hospital, and they'd come by like, why did you turn up that eye time? Turn it back down. And we'd sit there and have another, but he's not having any problems. It's been like this for 6 hours. See, it's fine. So we've actually been able to wean, look. So it's one of those things that just isn't talked about much that we really need to get back into the conversation. So starting with modes. Do we use a control mode? Do we use an assist mode? I think for the most part, control modes lend to giving us more stable oxygenation and ventilation. Every breath that they get is delivered by the ventilator. The problem that we have with some control modes is the baby can try to breathe, but they don't necessarily get the breath, so it causes some dysynchrony with the ventilator. So our assist modes allow our patients to trigger a controlled breath on their own. So there are settings that are modes that you can assist, so when they take a breath, it'll recognize that, it'll give them a fully controlled breath. So it still maintains that stability of ventilation. But there isn't always synchronicity between those as well. We'll get to that. So advantages that we have of assist modes from multiple studies and trials that occurred looking at between these two modes is the assist mode lowers and gives you more consistent airway pressures, thus lending to less intracranial pressure swings. Increased patient comfort, leading to less sedation needs and potentially quicker extubation times. Greater synchrony with the patient in the ventilator, so this gives us less air trapping and less airway leaks. So all positives. And it can overall improve oxygenation and ventilation, which are our goal strategies so that we can get off quicker. So to synchronize or not, kind of mentioned that quickly, not every mode synchronizes. And what we mean by that is whenever the patient, you have them dialed in to get 20 breaths a minute, As long as the patient takes 20 breaths a minute, it kind of synchronizes and it doesn't throw in its breath whenever it wants to, so you can get some double breathing, which can cause some problems. If anybody has actually breathed on a ventilator, you know when that happens. If you haven't done that, talk to your therapist or for the therapist in the room. Grab your nurses and do that. I do it with all the residents so that they know what they're doing when they order something. The advantages that we have of synchronized modes versus unsynchronized modes, and there are several studies, so I didn't pick out any one for these either, is you have larger, more consistent tidal volumes, which is a good thing and a bad thing. If you're synchronized, you get a bigger tidal volume, you can then dial it back down, so we don't have to give them as much support as we would have if they were on a non-synchronized mode. You have greater oxygenation and ventilation, thus because of the better inflation. You get a lower work of breathing, because your baby's a little bit more comfortable. Lower respiratory rates, because you're not having a ventilated rate on top of what they were trying to do anyway, so you get a couple double breathing going on there. But they saw no differences in mortality, and this is something that's really important. When they looked at the assist versus on a controlled mode, there was also no differences in mortality, and a lot of our ventilation data looks at an endpoint of mortality, or now mortality and BPD, but we don't look at comfort scores. We don't look at neurodevelopmental outcomes, and maybe we should, because not everything that we do is going to affect our mortality. So if it can help some of these other little pieces in between, it might be able to help us make a decision one way or the other if it's not going to affect the overall mortality score. So some of the bigger controversies has come in with volume versus pressure. And then the other controversies are some of our volume modes are really pressure modes. So when you get into the intricacies of a lot of how the modes work and how they deliver. So looking at some specific research there was a study that was done in 1997, which is an older study, by Sinan colleagues. And they did a randomized trial that looked at volume versus pressure ventilation. And they looked at a target tidal volume of 5 to 8 mLs per kilo. So if they were in a pressure mode, they targeted that as an exhale tidal volume. And they looked at this as an initial strategy from birth, if they needed to go onto a ventilator, for all preterm babies that had some sort of respiratory distress. So it wasn't if I developed respiratory distress later on, it was as an initial strategy that they really followed these kids. In their volume control groups, they had shorter ventilation times, which was statistically significant. And they had a trend towards lower BPD, which, as we know with our p-values that we're always looking at, we went less than 0.05. So it was not statistically significant, but it wasn't necessarily powered for this either. So they didn't, if they had larger patients, they might have been able to see that. But it was also, it was a pretty large trial to begin with. But this is kind of, one of the studies where we took where our tidal volume ranges really should be for our infants. So 5 to 8 is actually bigger than what some people use. We tend to go on more of the 4 to 6 range now. But as we talk about some of our volumes and our inflation pressures as we go on, having that lower tidal volume in itself isn't always a beneficial thing. You have to have your PEEP and everything else that matches up to really make that perfect picture. So in 2010, there was a Cochrane review that looked at 12 different randomized controlled trials comparing volume-targeted ventilation and pressure control. So when we say volume-targeted ventilation, for those that aren't familiar, we're looking at, they're oftentimes modes that deliver a pressurized breath, targeting a volume, so the pressure will vary with each breath. But it is a pressure breath versus a volume breath and has a different flow dynamics with the ventilator. So the thing to look at is when the Cochrane reviews, they throw a lot of different studies together to see if there is a better outcome than they got within that one study. So there were various different types of modes that they used. They didn't all have Draeger's, they didn't all have McKay's, they didn't all have PB840s. So each mode has a different name and a slightly different way of it works, but they were all, in essence, volume-targeted ventilation mode. So there's no way to say that one mode specifically works better than the others at an endpoint, but in that general category is what we're talking about. So their volume-targeted ventilation showed that it reduced all of the following outcomes compared to pressure ventilation alone. And these were looking at number needed to treat with their analysis. And for those that aren't familiar with that, number needed to treat is how many people do I need to treat to get the benefit from this therapy. So if your number needed to treat is 1, then everybody benefits. In general, with a lot of your pharmaceutical and cancer treatments, anything above 100 is fantastic because you only have to treat so many people in order to get that that benefit, which there's a lot of medications on the market that have number needed to treat in the 300 range, 400 range, but they're still beneficial because it's better than nothing. So considering all of the people in the world that have, you know, cardiac history or diabetes or whatnot, that it can really help. So looking at these number needed to treat numbers are pretty low. And it tells us that doing volume targeted ventilation can really significantly help a lot of the outcomes that we see. And these are very short-term outcomes within our kids. So death or chronic lung disease. We only need to treat 8 patients with volume targeted ventilation in order to not die, essentially, or get BPD, which is great. Pneumothorax, 17, hypercarbia, 4. So we can get a much stable CO2 levels using volume targeted ventilation than you can with pressure. And as we saw the first couple of slides, a lot of the problems that high and low CO2 levels give us when we're not really watching those to our brain. So that really helps to keep it more stable where you don't have to be on top of it as much. PVL in grade 4 bleeds as well, number needed to treat 11. So those were pretty big. So why don't we all do that, right? It's a good question. We'll get there. So PEEP levels. There's a lot of places, as you'll hear, a lot of people say we're PEEP phobic here, we don't like PEEP here, they're giving way too generous a PEEP there. A lot of times we think that we should be setting our PEEP according to the size. If you're little, you get a little bit of PEEP. If you're big, you get bigger PEEP. Instead of really taking a look at how much PEEP do you really need. The NICU that I'm currently in, again, not a preemie NICU. We have a huge chronic lung disease program. We have one of the 7 BPD centers in the country. Our average PEEP for our kids is 14 in our chronic lung disease group. We use very big PEEP levels, but it's necessary. And we oftentimes, when we get a new kid come in, there's about 4 of us standing around the ventilator just tweaking. Is that better? Is that better? Look at them. Is that better? Did we, you know, looking at the graphics, taking a look at the patient, looking at blood gases and looking out to try to find, it's not easy to find that sweet spot of all of your different vent settings, including your PEEP level, which is why it's not done routinely everywhere. And we literally, our group is at least 1 respiratory therapist, nurse, neonatologist from the chronic lung team, and one of our pulmonologists that do this when a new kid comes in that they're having a hard time ventilating. So we go back to animal studies. Unfortunately, this is where we have our data in for how to best set PEEP in the NICU, because there isn't a whole lot of ventilation research that's done on very specific ventilator settings in the NICU. So there were 3 different animal studies that suggest reducing the tidal volume and using appropriate PEEP can reduce lung injury. Now we see this for those that are familiar with ARDSNet or ARDS type ventilation. They use high PEEP grids. We're using 4 to 6 cc's per kilo of tidal volume in adults, where we're at 6 to 8 prior, and very high PEEP levels, up towards 20. In smaller tidal volumes. So we've gotten to the smaller tidal volumes in the NICU, but our PEEP levels just haven't gotten up to probably where they need to be to help reduce injury. So we don't want to get to the ARDS. We want to be more preventative, which is what more of the adult centers are starting to do now as well. And recruitment maneuvers in the NICU mostly occur when we're on high frequency than they do when we're on conventional ventilation. So some of the evidence suggests that it can be more helpful in determining appropriately PEEP levels by doing recruitment maneuvers, and it can also help to reduce lung injury by having the best PEEP level. So our alveoli aren't snapping closed and snapping back open, and that's really our goal. And there were 2 studies there, and the most recent one in 2003 that really helps to prove that. Again, the one in pediatric research, I believe, is also an animal study. But this is something that we've also seen in adult and pediatric ventilation as well, that they do that. They're on several of our critical care ventilators. They're open lung tool type options that can help us to determine the best PEEP settings. We can see our compliance and resistance levels, which can really help us determine best PEEP settings too. So there are some guides out there that can really help us get there so that we get the best PEEP level. But part of the problems I know that I've always come in contact with in the NICU, and several of the other therapists in the room can say too, is you do that, but then they say, okay, my optimal PEEP should really be 8, and then they're like, no, we're not gonna go to 8, turn it down to 6. Well, then why did I do all that work? So what's the point? But it's really just in our minds, you're 1,000 grams. You're only 1 kilo. You shouldn't have 10 of PEEP, and we kind of have to get over that a little bit if that's really what our patient needs. Inspiratory time. This is one of the ones that is technically looked at as a set it and forget it type mode according to age. And there are some guides, older guides out there that even tell you at certain ages you should only be at certain eye time levels. But this is something that is probably one of the biggest contributors to asynchrony that we see. And so it's one of the pieces that we probably need to concentrate a little bit more on, and some of us probably need to bone up a little bit more on the best ways to help determine what the best eye time is for that individual patient to help individualize ventilation. So too short or too long contributes to asynchrony. So again, we need to be Goldilocks, and we need to find that real sweet spot, just like we do with the CO2. There was a meta-analysis done in Cochrane in 2004 that looked at the effects of eye time on air leaks, BPD, and mortality. They looked at just those three things, and they looked at predominantly too long of eye times, but they looked at eye times in general. Nothing in their AIM statement did they say that they only looked at too long eye times. So they found that an eye time over 0.5 is associated with increased air leaks and mortality before discharge. Kind of makes sense, especially if you come from a preemie center and you're used to 0.3 or 0.35, you say, well, of course we shouldn't be that high. But it didn't affect BPD rates, surprisingly. And that was one of the things that was a shocker for those authors. I think they really thought that there was going to be a BPD issue too, because if you look at stretch injury, which is another one of ways that can cause lung damage, too big of an eye time can cause that stretch injury, as well as too high peak airway pressures. So one of the things that we need to keep in mind, yes, the Cochrane review came out in 2004, but all of the studies that they reviewed were done pre-antenatal steroids, pre-surfactant administration, and pre-newer ventilation strategies that we currently have. So we essentially can't keep this in mind at all. So when you're reading studies, you really want to make sure, and when they're referred to as here's how we should really ventilate our patients or do anything with our patients in medical care, if it's a review and all of their studies were done before a lot of our strategies, then it doesn't really tell us much of anything. So at this point, I don't know that 0.5 of an eye time isn't too bad. Some of common sense tells you for a certain size patient, it is. But we really need to be open-minded to look at that probably 0.30 might be too short too. So here's a way of looking at those too long of eye times, which I'm sure do still cause problems. There's a pointer on here. So you can see here where your cutoff is, where you have active exhalation is starting. Once you see active exhalation in your waveforms, that's when your eye time is too long, because your patient is trying to exhale. If they're trying to exhale actively and the ventilator is still trying to give them a breath, then you know that your eye time is too long. So those are some of the things that we can look at. It's not as easy to see if their eye time is too short. Chances are they're just going to be a little bit more tachypnic, but it's harder to really pick that out with just using the graphics if your eye time is too short. But you can definitely pick it up in the graphics if it's too long. So that's one of the things that we can look for, and even do more of a trial and error and turn up that eye time intermittently, little by little. When you start to see this, then turn it back, and you can try to get more of that sweet spot with your eye time. So some of the challenges that we see with all of these recommendations that didn't really tell us a whole lot other than we really need to think about the brain, not just the lungs, when we're talking about ventilation. And that's something that at my institution, we're rolling into a lot of our respiratory research, and our ventilatory research is starting to look more at longer-term outcomes. Because after all, as we saw our pictures of Jacob in the last one, we want a good outcome. And that's what the parents ask us all the time. Will they be normal? Will they have a normal life? So we have to start doing the studies to figure that out and looking at them longer. Take a little bit more time, they take a little bit more money, but in the long run, things that can tell us that are probably worth it. So some of the things we're going to look at with our challenges: proximal flow sensors. That's one of them. Those who have them, we know we need them. We'll talk about why in a little bit. But they're also a nemesis in some situations. Large airway leaks, we predominantly use uncuffed endotracheal tubes in the NICU. Why? It causes airway damage, but there's a trend, at least in the pediatric realm and in PALS, that says use a cuffed tube if you think you need a cuffed tube, especially if you have lung disease. We haven't really done that in the NICU yet. And as long as that cuff is taken care of appropriately, you shouldn't really have lung disease. So that's something that can help us in the long run. really there's too many options, and that's something else to look at. We have to get back to basics with ventilation, just like we do with everything else. All of the bells and whistles on a lot of our critical care ventilators are there to help enhance what our baseline knowledge should already be. And we see that with ACLS and PALS and NRP. Every single one of those courses concentrates on you must be doing good quality CPR. You have to make sure that your BLS is good or your advanced skills aren't going to help. So if you're not getting the basic settings set appropriately for that patient, then it doesn't really matter if I can do all these other really fancy things and collect all these different measures in pulmonary dynamics. If it doesn't help me with setting my basics, that's where we need to start. And then when do we admit defeat? No one really talks about that. No one wants to talk about it, but we kind of have to. Because at one point in time, when is your being on a mechanical ventilator or not being on a mechanical ventilator really stopping your neurodevelopmental progress? So one of the things that we always keep into consideration, especially our kids are on non-invasive, we try to keep them extubated as much as possible. But if you're not growing, you're not ventilating. You're taking too much energy to ventilate. All the calories that we're pumping in are going towards breathing, and you're not growing. So at this point, if we're not growing, we're doing something wrong, probably with ventilation, as well as other things that we need to keep nutrition into consideration as well. So our ventilator recognition and the ability to synchronize with the patient's effort is one of our huge challenges. We have to really take time to look at the patient, look at the ventilator, look at the patient, and see if things are matching up as they should. And is our patient really unhappy and uncomfortable? Because although it's easy to just say give them a little bit more sedation, it's really not the best thing for them. So we really want to make sure that we have everything as synchronized and we can tweak those little settings as best as possible. Proximal flow sensors help a lot, so that the sensing and delivery of breaths and all the measuring of all the dynamics that we're getting is happening right here at the airway. Our problem with those is they add extra weight, they add extra dead space, and there can be a lot of alarms and additional disconnects that occur because of having to do maintenance on our proximal flow sensors. If you're giving aerosolized meds, if you have an extraordinary goopy kid who's coughing up a lot of secretions, all of those things can cause problems with your flow sensors. A lot of older units have drafts. It's hard when there's a draft in the room and it causes extra humidity in your circuit, which causes problems with your proximal flow sensor. So there are some units that choose not to use them. And there are some ventilator companies that say, you don't need to. We have a proximal flow sensor, but our distal flow sensor works just as well. And you know, my prior unit, we used one of those machines. We did the test between the two. And the tidal volume, if you did all of your circuit calibrations and everything with a warm, wet circuit, and did your calculations over, then it actually was pretty close, their proximal flow sensor to their distal flow sensor. However, when you had little preemies and 1 ml of tidal volume makes a big difference, then 1 ml of tidal volume you need to have and you need to be able to measure. So for preemies, unfortunately, you really need to have that proximal flow sensor. It's the best. When your kids get a little bit bigger, you have to weigh those pluses and minuses. If it's causing way too many problems and we're having to disconnect all the time and we're causing all this additional trauma to their lungs and now that we just highlighted to their brains, we really have to think about that and really be cognizant of it. So at the bedside, we have to weigh our pluses and minuses. Airway leaks, huge. Who wants to re-intubate this kid who's really not doing well, is hemodynamically unstable, but the alarms are going off like crazy, so it's causing a lot of extra problems because you don't know when, so you just ignore what's going on with the ventilator. All that's alarming you. You don't really want to ignore it because it could be something major this time because everything, you know, reacts the same. So the airway leaks are a huge problem, and you have to, again, weigh those pluses and minuses to re-intubate, upsize a tube or put in a cuff tube or deal with the problems. So really, you know, how big is too big of a leak? And that's really one of the bigger questions. So in addition to when you have your proximal flow sensor in line and you have this large leak, you're not getting accurate tidal volumes. You're getting the inability to really volume ventilate. You can't really maintain FRC. You're losing your PEEP as well as your volumes. You're reducing the ability to trigger. So your patient can't trigger even just with the airway sensor that close. So then you have your asynchrony again that we tried to get rid of by putting the flow sensor in line. It can also cause auto-triggering. And unfortunately, with some of these babies, because their airways aren't as formed as our older kids, you could be fine right now until you flip them over, and you get very positional leaks as well. So these aren't things that are easily taken care of, and you can't keep them in just one position all the time, although we sometimes do. So really, a lot of the new ventilators have come up with leak compensation. This has been out for years, which is great. It helps to compensate for some of the leak a little bit, and what they do is add additional flow to the circuit so that they can maintain the PEEP level that we have set. There is a group of neonatologists that don't really like the leak compensation, because that extra flow that they're adding, the infant can pull from, and they can get extra tidal volumes and extra support with their breaths that they can't control for. So, you know, again, you have to weigh your pluses and minuses. What do we want more? Do we want the synchrony and all the problems that are listed up there, or do we want to, you know that breath to breath it could change a little bit? Variable. So really, back to the question of how much leak is too much leak. And a lot of centers that are very big volume target ventilation centers say about 30, when you hit 30% leak, they switch off volume mode. If they have decided that re-intubating and getting rid of the leak is not the best option for this kid at this time, they'll go to more of a pressure mode and more controlled mode. So they've done that calculation in their head and say, this is what we're going to do. When you look at a lot of different research studies, as far as delivery for medications, the how true a lot of your pulmonary mechanics, and that they're able to tell us now your resistance, your compliance measures, how really good your tidal volume measurement is. They look at 10% leak as a cutoff. That if it's greater than 10% leak, you're starting to lose some of the accuracy that you can get from all of the different bells and whistles from the machines. So that's one of the things to think about. And again, each unit is going to make up their own decisions, but really when you're getting close to that 30% leak mark, you're not really ventilating effectively with the proximal airway sensor in place, because a lot of what it's trying to measure in order to adequately ventilate is coming out the side, so it can't measure that. So that's one of the things to really keep into consideration with the leak, and when is too much. Most units have their own cutoff that they'll go for. That sometimes takes a long time for the physicians to get to that common decision to make that. And then still sometimes you don't hit that, because really for that patient it really is going to be more risky to re-intubate them than deal with that leak that's bigger. So again, we need to go back to remember our basics of ventilation and lung injury to really make sure that a lot of these settings that we're putting out there are really not causing more problems. We need to use enough PEEP. How much PEEP is enough? Again, we still haven't gotten that answer to yet, but we know that we definitely need to not use too little because it causes problems. We need to not over-distend. So giving too much is bad, and you really need to watch your peak airway pressures on the other end. And we really need to utilize our graphics to really help to assist us in telling us which one, where we are at each individual place. So here's one of the, sorry, that one part on the left isn't going as it should, but you can see that with every breath, when we're on conventional ventilation, we're hitting injury points on peak inhalation and peak exhalation. So those are, we really have to understand that, and that's where our PEEP comes in. When we do high frequency, we're really ventilating in this range, and we stay in the safe range the entire time. And for those on this side, this is the range where we really try to stay in the green zone when we're doing high frequency ventilation. So if you're able to use a higher level of PEEP, you can get this injury zone a little bit smaller on this side, smaller tidal volumes, smaller peak airway pressures, takes your injury zone on the top end down as well. And we want to try to get it as close to the middle as possible, at least for your lungs. That's the goal. And as we showed with a lot of the studies in the beginning, it also can really help with your brain as well, and making sure that those velocity changes with ventilation aren't occurring with your cerebral hemodynamics, which are huge. So here, when we're looking at our graphics, what does it really tell us? In this area here on our first graph, this is our critical opening pressure at this point, and that's where we really want to have our PEEP set a little bit higher than that. So this is where that critical opening pressure is occurring. So once we look at our graphics, find out where this zone is, and this is a loop of someone who has too little PEEP and is too underinflated. So it really tells us when we can look at those, and unfortunately these things swing by really quickly. greatly now, most of our ventilators have freeze frames. So you can actually push freeze on your screen. You can see your ventilator graphics and you can really measure them. So we really want to find out where a PEEP is here. That's the best spot to put your PEEP. Some camps of thought say you should set 2 above that so you never get to that closing pressure, 1 above that. But that real decision comes into how big is your patient and what PEEP level is that and where you're comfortable with. And then when you raise the PEEP up, here's after a loop afterwards when we had more adequate PEEP, you get higher peak airway pressures, you get more volume, so then you can really dial that volume back down, bring those peak airway pressures back down, because once your lungs are open, they more efficiently will ventilate. So our peak airway pressure up here and more additional volume with all this space. So it really isn't just setting one setting and hoping that it corrects everything. So one of the other challenges that we really come in contact with is when do we trach? When do we admit defeat and say, we're not going to be able to get this patient off the ventilator? And at one point is us continuing to try to wean and extubate and reintubate and wean and extubate and reintubate, really causing harm neurodevelopmentally for them. And we don't really know that yet. So recently, there was a study that was just published that looked to see what is the risk of death and tracheostomy in infants with severe BPD from referral that are referred to regional NICUs. So there's a Children's Hospital Center network that collects all this data. They all dump their data in together, and they did a retrospective analysis. The primary outcome was death or tracheostomy before discharge. They stopped looking at that time. So they looked at all babies who had severe BPD that were born less than 32 weeks in 2010 and 2011. And they pulled all that data together from several different hospitals. In the back of the study, you can see there were 20-some hospitals that contribute their data to the Children's Hospital Neonatal Database. And for severe BPD, they defined as the need for FiO2 of oxygen greater than or equal to 30%, need for a nasal cannula of 2 liters per minute or greater than 2 liters per minute, or they had any sort of positive pressure ventilation when they hit 36 weeks corrected gestational age. And these are going off of more of the, not strictly the NICHD, NIH definitions of BPD, of severe BPD, but they did a little bit of a variation with them. So this is a study. It was just published. It's actually only in the electrical format online right now. It's not in the journal quite yet, so I couldn't give you a full bibliography, but Journal Perinatology in 2014, and you can take a look at it online. And the results that they showed was that all of the below that we'll show you were associated with the risk of death or tracheostomy. Their gestational age at birth, surprisingly, not the earlier. Later age at referral for pulmonary management to another center. Mechanical ventilation at time of the referral to their center. And a clinical diagnosis of pulmonary hypertension on referral. And it could be clinical, not meaning I went to the cath lab, we measured pressures, because that doesn't always happen well, but when they had that clinical diagnosis at referral. Systemic corticosteroids after the referral. So once they were referred at that higher age, post-conceptual age, that they actually needed steroids. And then occurrence of bloodstream infection after the referral as well. So the sicker you are, the more likely that you're gonna die or get a trach. We're not completely surprised at that. But having a later gestational age at birth was a big surprise to a lot of people. And the authors actually very much state too that they're not saying that you must refer your patients sooner. They weren't really powered to take a look at that, but it was really something that they saw that the older they were at referral, the worse off that the babies were in the end. So we really have to really go back to not how we're going to fix them and how we're going to get them off. Once we hit to a certain point where we know we're having a problem neurodevelopmentally, because it's not really always the ventilation that causes neurodevelopmental problems. It's having that endotracheal tube in place to begin with. They can't sit up, they can't smile, they can't get their hands to their face and do all of we try to keep their hands away from their face so they're not pulling out their tube. So there's a lot of ways that just having a trach in place, they can do a lot more things. PT and OT can do a lot more with them to try to get them to those milestones. So a lot of times it's just getting that endotracheal tube out. And it can aid with weaning and get them on a lot lower settings to be able to go home as well. So just to recap, some of the things that from what the evidence and some of our challenges experience have kind of told us is we need more consistent tidal volumes with our babies, more of the 4 to 5, that should say 48, cc's per kilo tidal volume, appropriate eye times, which we don't have a good estimation as the best way to set those, but using our graphics, we can see what too long is. Using appropriate PEEP levels, using our graphics again to really help us along, but needing to find that sweet spot. Permissive hypercapnia is a good thing, as long as it's not too permissive. You can't go too high because that also causes problems. And we really need to create this brain-supportive respiratory strategies, of which we don't really know what that is, but we need to try to figure it out. And some of that could be minimizing disconnections, which we all try to do anyways to help with our VAP bundles. Minimizing suctioning, as we know that that causes problems. A lot of times you suction just because you're in there for hands-on or I'm already in here, but a lot of these kids don't have a lot of secretion, so is it really necessary if you're not seeing changes on a ventilator to really need to suction them? So there's a lot of other things that we could do in our day-to-day care or hourly care of them that could really help in our respiratory strategies to really reduce. So for me, and I don't know about for you, but I came with a lot more questions than I did answers when going through this, and that goes to tell you how little there is in ventilation research within the NICU. We think there's a lot more than there is sometimes in pediatrics, but there's a lot of things that we really need to look at, and there's a lot of things that we need to make sure that we're really narrowing down. How do we determine the best PEEP level? Can we go back to graphics? Is there something that all of our new modes of ventilation have that we really need to look at? Can we come into one common strategy that there is something available on each of our critical care ventilators that people can look at as here's the best protocol or the best way to really help determine what your best PEEP levels are? And if, for a preemie, 8 or 10 a PEEP is what's recommended, is that really detrimental to them? We don't know. But I'm sure that IRB would have a field day with that study when we put it in. So it's going to be difficult to do. How much airway leak is acceptable? And at what point? Is it 30% when we're not really getting good numbers and good feedback where that ventilation is really affected? I don't know that we really know this. Is 10% too low? And should we really explore the use of cuffed endotracheal tubes in this population as an option as long as they're maintained? There haven't been research studies on cuffed endotracheal tubes in the neonatal population in a really long time. And the care of endotracheal tubes and the types of tubes that we have come a long way since then. So it might be time to do that again so that we can really reduce the amount of airway leak that we have. And then what is the best time to intubate? I know we didn't talk a whole lot about non-invasive ventilation, but we can see that there's this huge trend towards not intubating. Above all, when you have to intubate, you failed in some institutions, but really we have to look at it as what the patient is telling us, and if they're not growing, they're potentially not ventilating well. If you're on non-invasive ventilation for months and months, and your growth chart is dropped, and that's the only thing that's changed, then you probably need either more protein, but then can your gut really take increased feeds? Can you really add more protein to what's really in there? I'm not the expert on nutrition, but I hear our nutritionists talk about it all the time in stress. But maybe we really need to intubate them and give them a break and get them to grow and then think of something differently. We have a challenge in non-invasive ventilation because we don't have good interfaces. A lot of the interfaces that are out there just don't work well. They may fit the face well, but how we put it on their head is it doesn't stay put, especially when they start to grow and they start to feel better because they can oxygenate and ventilate and they start rolling all over the bed. So we have to find a better way to really keep these non-invasive interfaces on them without getting a constant plastics consult every single time we have to do that. We need to not destroy their faces. So what is brain supportive respiratory strategies? We kind of talked about that a little bit, and it's one of the things that we really need to try to dive deeper into. Again, this is a term that I picked out of that one study, but it is something that people probably need to pay more attention to with our ventilation strategies and how it's affecting the patient overall, not just the lungs, but also the brain. And should nutrition play a bigger role? I know there's a lot more centers. Boston Children's is doing a ton of research now, mostly in the PICU setting because it's easier, and looking at indirect calorimetry. But that big airway leak, again, can cause a problem because if I can't capture all the gases coming out of the machine, I can't do an indirect calorimetry measurement to really see if our nutritional level is good. When we do rounds every Tuesday on our chronic lung disease kids, and we pretty much go from a little skinny kid who's a little skeleton kid who's definitely not getting enough to a Buddha baby, where their abdomen is going up, and do we wonder why they're tachypnic when their abdomen is so far pushing up their diaphragm? So we need to try to find that balance. So we really do need to concentrate on our nutritional levels a lot more than we potentially do, but we have that challenge. And how do we do that in that population? A lot of our current indirect calorimeters also don't give you a good measure below a tidal volume of 50. And most of these kids have that. So that's a challenge to our other companies that do that as well. And then making sure that future research really needs to look at the total patient, not just ventilation and oxygenation, not just mortality or BPD as our outcomes. Because maybe they don't die, but potentially they're less asynchronous, they're more comfortable, their comfort scores are better, they get to their milestones better. So if we can get to our developmental milestones quicker, maybe be on the ventilator a little bit longer, or maybe not. If mortality doesn't change and our time to extubation doesn't change, but we have a better patient overall, that really is our end goal. And that's really what every parent asks us to say, are they going to be normal? And if we can do everything possible, but we don't look at it in a lot of our research. So that's one of the challenges that we talk about in our meetings to decide on what research we're going to do next in our NICU, that we all kind of, is my challenge that everyone needs to kind of look at. So questions, I know it's a lot. In very general, it was a huge topic. I could have talked for hours, so I had to try to cut it down at some point and not go too in depth. But if there are specific questions or things that I didn't go over, I'm happy to discuss it.